This is Dr. Pete Sloan. I'm returning for part 3 of a 4-part series on basic interpretation of pulmonary function tests. In part 3, I'd like to review some common pitfalls in the interpretation of pulmonary function tests, as well as some common patterns of pulmonary function test abnormalities. First, pitfall. Best shown by the example below. In this example, the patient has a good quality study, which I haven't shown, and the FEV1 ratio is low compared to normal, signifying obstruction. The FEV1 is extremely low at 40% of predicted, so we know this is severe obstruction. An amateur would read this as superimposed restriction because of the low vital capacity, but we know that in moderate or severe obstruction there can also be a low vital capacity because of incomplete exhalation. In this example, the residual volume is extremely high from air trapping, and the total lung capacity is actually mildly elevated, showing that there is no restriction. The pitfall would be interpreting the low vital capacity of restriction when in actuality there is absolutely no restriction. Be careful here. Second pitfall is improperly comparing ratios from one study to the next. In this example, the pre-bronchodilator FEV1 is 1 liter, FVC is 2 liter, ratio is 50%, clearly obstructed. After bronchodilators, the FEV1 improves by 25% to 1.25 and the vital capacity improves from 50% to 3 liters. However, the ratio goes down. An amateur would say the ratio went down because the patient's worse. A keen eye would observe that both the FEV1 and FVC went up together, although the vital capacity went up even more. Since the denominator of the ratio has gone up more than the numerator of the ratio went up, the actual ratio went down. In this case, a lower ratio does not mean the patient is worse. The patient's truly better. So just be careful in interpreting ratios. They really are a relative component, and you should be interpreting the individual components, FEV1 and FVC, to see how they did after a bronchodilator. A third pitfall is looking at the numbers without looking at the tracing. In this example, the first effort, just the numbers alone, shows an FEV1 of 1.25, an FVC low at 1.56, and a ratio of 80%. In the absence of obstruction, because the ratio is normal, we would assume there's quite a bit of restriction. However, the tracing from the first study is shown in red. The patient only blew out for 0, 1, 2 seconds and stopped the maneuver before the required 6 seconds. On a repeat study, the patient started in a similar fashion at 1 second, was also at 1.25 liters, but went the entire 6 seconds, blowing out a total of 3 liters, and now the ratio is 42%. The difference is they completed the maneuver 6 seconds. Because of short expiratory time, the vital capacity was not completed in the first maneuver, therefore 1.56 underestimated the true value of 3. And for that reason, the ratio overestimated the true ratio, all because of a short expiratory time. Easy to see if you look at the tracing, difficult to see if you just look at the numbers. In the final example of a pitfall is always make sure the results make sense. In this example, the patient has a normal vital capacity compared to predicted at 5 liters and a slightly low FEV1 with a slightly low ratio indicating very mild obstruction. Yet, the residual volume is extremely high at 270% of predicted and the total lung capacity extremely high at 128%. Although we know that obstruction is associated with air trapping, it does not make sense that very mild obstruction would be associated with very severe air trapping. In this example, the patient did not seal his mouth during the helium dilution maneuver, causing a falsely low final helium concentration and a falsely elevated residual volume and total lung capacity. I'd like to turn our attention to some pulmonary function tests, patterns of disease. In the first column, I show the classic pattern of asthma. starting with the ratio, which should be low because asthma is associated with obstruction. The vital capacity can still be normal or in severe obstruction low, but we always expect the FEV1 to be low. Residual volume may be high and total lung capacity may be high because of air trapping. The diffusion capacity is high, and even when accounting for the lung volumes, remains relatively normal. Tests of neuromuscular strength of the diaphragms and accessory muscle, the negative inspiratory force, and the maximum expiratory force should be normal in asthma. In classic COPD, such as emphysema, the FEV1 can be quite low, and of course the ratio is low. And like in other obstructive diseases such as asthma, the residual volume and total lung capacity is normal or high. Now, the difference between asthma and emphysema is that in emphysema, the diffusion capacity is low, related to loss of effective alveolar capillary interface on the basis of emphysematous loss of lung tissue. The neuromuscular strength is normal. In interstitial lung diseases, the ratio of FEV1 to FVC is normal or high, signifying absence of obstruction. We sometimes see a high ratio of FEV1 to FVC due to increased elastic recoil from stiffened lungs. With a normal ratio, we find a low forced vital capacity, indicating probable restriction, which is confirmed by a low total lung capacity. The diffusion capacity is also low, but it's low out of proportion to the total lung capacity. So that if the total lung capacity is 70%, the diffusion capacity might be 40%, making the diffusion capacity corrected for lung volume still low. Neuromuscular strength is normal. Obesity is a restrictive pattern similar to interstitial lung disease, but in this case the diffusion capacity and the total lung capacity tend to be low in proportion to each other, so that the diffusion capacity when corrected for the total lung capacity is normal. In obesity, there tends to be a disproportionately low expiratory reserve volume, so that the end of a normal tidal volume ventilation is very close to residual volume. The neuromuscular strength is normal in obesity usually. In kyphoscoliosis, the pattern is very similar to obesity. They both extrinsically restrict the lungs, but there's no reason to believe the expiratory reserve volume is particularly low. And also, the neuromuscular strength is normal. Obesity and kyphoscoliosis are very similar patterns on PFT. Sometimes we can discriminate the two by the expiratory reserve volume being particularly low in obesity. Chronic pulmonary embolia is a special case as an example of what we call an isolated diffusion deficit. Simply put, lung functions from PEs are normal, but from chronic pulmonary emboli with overall accumulation of a clot burden in the capillary bed, the diffusion capacity gets clipped off, there's loss of effective circulating area of diffusion, and the diffusion capacity stands out as the main deficit on pulmonary function tests. Other diseases that have this pattern are chronic vascular disease, such as pulmonary vasculitis. Finally, in neuromuscular weakness, the lungs are restricted, as several other restrictive diseases are. The ERV is also low, looking very much like obesity, but in neuromuscular weakness we can distinguish this from obesity because the negative inspiratory force and maximum expiratory force is low.